emergency departments, we don't often get the opportunity to partake in the resus of newborn infants. Nevertheless, there are times when a mother will turn up at your ED with the birth of her baby only moments away. In such cases, we have to be ready to implement resuscitation of her newborn infant. The very fact that this is so unlikely is also what causes our fear of the scenario. We don't know the drug doses as well, and we aren't as familiar with the correct equipment. It takes time to unearth the neopuff and the paediatric resus trolley. So today, I'd like to walk you through the algorithm for the resuscitation of newborn infants. Your initial assessment should address breathing, tone, and heart rate. Ensure that head, neck, and jaw position allow for airway patency. Set up your positive pressure ventilation equipment if the infant's heart rate is less than 100 per minute. Assessment of tone is subjective, but a very floppy infant is highly likely to need active resuscitation. Brisk but gentle drying with a soft towel should be used to stimulate the infant to breathe. Slapping, shaking, or holding the newborn upside down are potentially dangerous and should not be used. Heart rate can be determined using a neonate stethoscope or by feeling for pulsations at the base of the umbilical cord. Pulse oximetry provides a continuous display of heart rate within about a minute of birth. If the heart rate is persistently less than 100 beats per minute, assisted ventilation should be commenced now. The aim of ventilation in newborns is to establish their functional residual capacity. Ventilation is judged to be effective if the baby's heart rate is sustained at greater than 100 beats per minute. There should be slight rise and fall of the chest and upper abdomen. Only consider suction if there are obvious signs of obstruction. Good technique and knowing your equipment are vital in achieving adequate ventilation. If target pressures are not being met, check for leaks or inadequate gas flow. If pressures are being achieved but there's no chest movement, adjust head and neck positioning, increase inflation pressure, and consider use of alternative airways. If suitable equipment is available, a positive end expiratory pressure of at least 5 can assist with lung expansion, help establish functional residual capacity, and improve oxygenation. High levels of PEEP, 8 or above, should be avoided as they may reduce pulmonary blood flow or cause pneumothorax. Blood oxygen levels of newborns can take up to 10 minutes to rise above 90%. Even brief exposure to excessive oxygenation during resus can be harmful to newborns. Therefore, air should be used initially, with supplemental oxygen reserved for those whose SATs don't meet the targets shown. Assess for response after each step in the algorithm. Every 30 seconds is recommended. Move to the next step if heart rate, breathing, tone, and oxygenation do not improve. At this point, chest compressions may be added, but only if you're sure that ventilation technique has already been optimized. Compressions are indicated when heart rate remains below 60, despite 30 seconds of adequate assisted ventilation. The two-thumb technique is strongly preferred, with 3 compressions to every 1 breath. Effective compressions will show pulsations on the oximeter trace. Aim for 90 compressions per minute. Knowledge and skill allow for the best conditions when intubating neonates. Attempts should be limited to 20 seconds to minimize bradycardia and oxygen desaturation. Whilst there is evidence that rapid sequence induction is beneficial to infants needing intubation, it is not part of the official algorithm at this time. We have now reached the bottom of the algorithm, and this is where venous access, adrenaline, and fluids are considered. If you have a full resus team, someone can be working on access while the previous steps were taking place. The preferred access in newborn infants is the umbilical vein, which can be used for both adrenaline and fluid administration. Administration of drugs or fluids should not detract from the continuity of efficient ventilation and chest compressions. Adrenaline should be given as close to the heart as possible, preferably through an umbilical venous catheter. In the setting of massive blood loss, normal saline may need to be followed by blood transfusion. Once adequate ventilation and circulation have been established, the infant should be assessed in a special care nursery where appropriate care can be provided. Transport or retrieval should be arranged if there is no such facility on site. Difficult resuscitations are stressful for the staff, so efforts should be made to debrief after such events. It's appropriate to consider stopping resus if the infant's heart rate has remained undetectable for 10 minutes. A decision to continue resus efforts beyond 10 minutes when there is no heart rate is very complex. Every opportunity should be taken to keep the parents informed as much as possible during this time. If it is decided to withdraw or withhold resuscitation, care should be provided in a way that is focused on the baby's comfort, if signs of life are still present, and dignity, and on support of the parents. Witnessing the resuscitation of their baby is distressing for parents regardless of outcome. On a personal note, my son Christopher was born via emergency C-section with an APGAR score of 0. After an initial failed attempt, he was intubated at 3 minutes old. After 2 doses of adrenaline, his heart rate increased to over 100 by the age of 11 minutes. He subsequently spent 2 weeks in a special care nursery. Christopher is now 16 years old. After his video, One Switch, One Head, The World, was released on YouTube last year, he was dubbed the most inspirational geek in the world. So from personal experience, I can assure you that each and every person involved in critical care is doing one of the most important jobs in the world, and you do make a difference. Thank you for listening. You can find further resources on this topic by using the QR code to visit my website. Your feedback and contributions would be most welcome.